In this particular section, I'm going to start with some, like what I call chunking. So you're going to see on your PowerPoint slides on Concept 8 where they're color-coded. So each probably 10 to 15-minute lecture, I'm going to concentrate on 4 or 5 slides and really showing you and going into what it is that you need to focus on in regards to fluid and electrolytes. And as I'm going through the reading, Giddens was a great review for Patho. You're going to see where it coincides some with what's in your Lewis book. And I concentrate on probably about those 10 pages in your Lewis book is where a lot of my lecture material and my slides and things come from. So if you're doing the reading, that's where you're going to look at. And when you get into the pediatric book, I think I say it on your handout to kind of skim these pages and really look at the differences. There's going to be a lot of similarities and there's going to be some subtle differences with children in fluid and electrolyte imbalance. So the goals of this presentation is to identify the populations and risk factors, and by the time we're totally done with all the different sections, all of these things will be completed, these objectives. Recall the objective and subjective assessment of each type of fluid and electrolyte imbalance. Identify clinical management for patients with extracellular fluid deficit. Identify clinical management for patients with extracellular volume excess, and then identify clinical management for patients with electrolyte imbalances. So to start out, looking at this, this definition comes from your concept book or your Giddens book. The fluid and electrolyte balance is a process of regulating the extracellular fluid volume, body fluid osmolalities, and plasma concentrations of electrolytes. I mentioned, I think, in a previous lecture, or maybe it was one that I talked about in a previous lifetime, who knows, that with fluid and electrolyte balance, think of it like a scale. Our body has a way of creating a homeostatic type of environment. So when one of our fluids is off or one of our electrolytes is off, our body has a way to compensate. So we're going to talk about what happens when our body's having a difficult time compensating and what our role as nurses is going to be. The scope of the concept, we're going to talk extensively about the extracellular volume deficit, optimal extracellular volume, and excess, and I mentioned this in my pathophysiology review. Also where we can have our optimal osmolality to dilute or to concentrated, and then hypokalemia versus optimal potassium versus hyperkalemia, which is high levels of potassium, and then I will be going into later on in these presentations talking about calcium, phosphorus, magnesium as well. So let's talk for a minute about the risk factors associated with fluid and electrolyte imbalances. And there are certain populations that are at greater risk. Infants are at great risk for fluid and electrolyte balances because they have a high metabolic rate. Okay, they are breathing faster, their pulse rates are faster, so what this happens is this increases fluid loss and results in a rapid turnover in fluids. So with infants, they also have immature kidneys that are limited to their ability to conserve water. So they can have what they call insensible fluid loss is greater than adults because of the more rapid respiratory rate in infants. Okay, so meaning, and when I use the word insensible fluid loss, I'm talking about what they lose from their respirations, what they lose from sweat, what they lose from tears, okay? So they have a much greater respiratory rate, which is going to cause them to lose that fluid faster. And they also have a proportionally greater body surface area. They're tiny, okay? So it doesn't take a lot for them to lose that fluid. Similar to the very young, the very old are also at great risk for fluid and electrolyte balances for a number of reasons. Their thirst sensation is blunted. The kidneys are less able to respond to ADH, which is the antidiuretic hormone. Okay, and so what this happens here is it impairs their ability to concentrate and conserve water. Okay, so they're going to end up putting more fluid out. These age-related changes create risk for dehydration, and when placed in context of patients with chronic heart failure and kidney disease, the likelihood of there's a huge or larger likelihood of fluid and electrolyte imbalance. Infants, as well as the elderly, are usually dependent on others to give them food and fluids, okay? And so this is the other thing. If they can't tell us what they need, then they're going to be at a higher risk. And when we get over into this next block, this is actually out of your, I think your maternal child pediatric book, Wong, I think, is one of the authors on it, and this is evaluating the extent of dehydration in children. And this is an important slide because it really does go into and talks about mild, moderate versus severe. With infants and children, if they have a significant weight loss greater than 10%, then this could be from dehydration. They're very much going to be much quicker at going into dehydration than an adult, kind of what we said just a few minutes ago. Their pulses may begin to get slightly increased, respiratory rate deep and rapid as they get into that severe range. Blood pressure may be normal at first, but then they get a little bit orthostatic, and then they get into orthostatic and almost shocky. They become hyper-irritable and lethargic and severe, and when they're in moderate, irritable, and more thirsty. Thirst becomes very intense as they get more into the severe category. Their mucous membranes may go from normal and mild to very parched and severe. Tears become decreased or absent, and they have sunken eyes. And I can remember that being something that the teachers kind of drilled into our heads when I was in nursing school. As they start to lose those tears, we start to look to see, are they crying, are they not? Their fontanelles of their head, anterior fontanelle, normally it's normal, but if they're dehydrated, it'll be sunken in. They might have a visible external jugular in mild, but then that disappears as they get into severe. The skin, as they go from capillary refill greater than 2 under mild to very delayed greater than 4 seconds, and then their skin will become tinted and cool, and they'll have acrocyanosis or mottling, which means their extremities will be almost a bluish color. And then their urine-specific gravity is going to change, greater than 1.020, and then gradually getting into oliguria and then anuria, which is the absence of urine. A general history of any patient with dehydration or any patient that is having fluid and electrolyte imbalance, I want to kind of hit on the general history of how you might start to begin to suspect that somebody has a fluid and electrolyte imbalance. So the symptoms are nonspecific sometimes, so we have to look at the symptoms in the context of the risk factors that are present. Okay, is the patient out in 100-degree heat? You know, are they having vomiting? Are they having diarrhea? Or do they have a history of organ failure where they have kidney, heart, liver disease, things like that that could manifest into fluid and electrolyte imbalances? Are they having unexplained nausea? And are they tired? Are they dizzy, short of breath? Are they having muscle cramping or difficulty walking or muscle weakness? Edema or sudden changes in weight. And when we say sudden change, you're going to learn that we weigh patients, and 2.2 pounds equals a liter of fluid. So if we're seeing that, that could be significant of a fluid and electrolyte imbalance. Renal and endocrine disorders. You're going to find when we talk about renal, do they have kidney disease? Do they have, you're going to figure out once you take that particular section with kidney disease, there's different stages of it, okay? As we get older, our kidneys begin to not function as well. But we can also have chronic diseases and disorders that affect our kidneys, such as diabetes, where it causes damage to the kidneys themselves. Other types of endocrine disorders like parathyroid hormone, Cushing's disease, diabetes insipidus can all create problems with fluid and electrolyte balance. We also need to question our patients regarding their intake and output. What is the type and quantity of water? If they're just drinking Pepsi or soda sometimes and not drinking free water or tap water, that may not be good. We also want to talk about their sodium and their potassium replacements. What are they taking? And then look at their medication history. You're going to learn about different diuretics, digoxins for cardiac, and all these types of medications you're going to learn as you go along can manifest and create problems with fluid and electrolytes in our patients. Dietary supplements as well. Are they taking sodium supplements, potassium supplements? Are they taking vitamins, things like that, that could create and manifest problems with fluid and electrolyte? A general overview of fluid and electrolytes in regards to assessment abnormalities is when you're assessing a patient, usually doing a head-to-toe assessment, you're going to look first at the skin. You're going to check to see if they have poor skin turgor. Is it tinting? Is it is it dry? And remember, the older population, the skin turgor may not be a good assessment tool to use because their skin becomes less elastic as they get older. Is their skin cold and clammy? Sometimes with perfusion, if we don't have enough fluid, we're going to have reduced perfusion. So we may have cold, clammy skin. We could have pitting edema, or if they're very dehydrated, they could have flushed and dry skin. Pulses, you're going to find when you're checking pulses, And as we go along in these sections, you're going to figure out which patients with different types of electrolyte and fluid imbalances are going to have bounding pulses versus which ones are going to have rapid, weak, and thready pulses. Sometimes weak, irregular, and rapid pulses could be significant of fluid and electrolyte, or weak, irregular, and slow. So as we get along, like I said, you're going to figure out which ones are which as you learn the signs and symptoms of each particular problem. Blood pressure, they could be hypotensive versus hypertensive. And remember, if they're hypotensive, think low. They don't have enough fluid. Something's going on. Hyper means they have too much fluid. It's elevated blood pressure. Respirations could be rapid, especially in patients that have fluid volume excess. They could be short of breath because they have too much fluid or have crackles in the lungs. And restricted airway goes along with some of our things like with our calcium, hypocalcemia, hypercalcemia, that we can have stridor and restricted airways where the airway becomes almost spasms. The skeletal muscle assessment that we'll be looking at, we may have muscle cramping anytime with individuals that have fluid and electrolyte imbalances. Muscle weakness is a sure tell sign when someone comes in with weakness, or Trousseau's and Schaaf's sign, and I'll explain those a little more when I get into the specific electrolyte imbalances that you will see those in. Neurologic problems, as an overview that you will see, tremors and seizures may occur with high levels and reduced levels of electrolytes, irritability with dehydration, as well as some of the other electrolyte imbalances, fatigue, confusion, and then decreased level of consciousness. So these are some sure tell signs that we have something, particularly may have something going on with electrolyte imbalances. So this concludes this overview of assessment abnormalities. And we'll continue on. The next section I'll be doing is extracellular and intracellular fluid, extracellular volume deficits and excess, and going through lab values and things like that. That will be part 2.